Hey, it's Justin Harvey. Thanks for tuning in to the Anesthesia Success Podcast, where we take a close look at important topics pertaining to business, practice management, personal finance, and careers for anesthesiologists and pain management physicians. On this show, I work hard to take your critical questions straight to the experts. Thanks for listening. What's up, everybody? Justin here. I want to start this episode with a special message. I'm going to be doing some more unique one-time type of episodes in between their regularly scheduled programming on a weekly release schedule to do coronavirus updates and talk to physicians in unique places of leadership, of operations, administration, and clinical activities over the coming weeks, just to provide resources for you, our listeners, to talk about what's going on, what are people seeing and doing, what's been working. I'm obviously not a public health expert, I'm not a doctor, but I want to facilitate as many of these conversations with people who are doing really great work as possible. I would also love to hear your feedback during this time, if there's anything that would be helpful as far as things that you want to hear on the podcast, or even other resources that you're finding helpful that you could direct my attention to that I could call out on the show. That would be great. As always, thanks for listening. On a personal note, as a physician spouse, I'm deeply grateful for the sacrifices that our men and women in white coats are making right now to help keep the public safe. And during a very scary time, it's sobering and also heartening to see how quickly physicians are just throwing themselves into harm's way. Yeah, in ways where there's not a lot of certainty right now. But one thing is certain, and that's the spirit of self-sacrifice that exists in the anesthesia community and beyond is something that is really awesome. And frankly, our society is going to benefit massively from in ways that they don't even understand or appreciate. So from me to you, thanks for the work that you're doing. Keep it up. Keep your chin up. Hug somebody today. Well, no, don't hug them. Give them, maybe an air high five, because we're in this together. And then one quick note about the upcoming episode. The audio quality is a little sketchy on the front end. I'm talking with Dr. Shelly Farrell from Germany, and our internet connection was a little bit patchy, but things get better a few minutes in. So I think this is really excellent content and would love for you to check it out. So if it's a little weird up front, hang in there, it gets better. Thanks for tuning in. Hello and welcome to this episode of the Anesthesia Success Podcast. We have a very special guest today who I'm really excited to be speaking with, Dr. Shelly Farrell. If you recognize the voice who is about to follow mine, it's probably because you've listened to his podcast, the Anesthesia Wise Guys podcast. I have enjoyed the bits of non-clinical content that they've shared over the years, and I'm really excited to have him joining us from Germany today to talk about how they've responded in their anesthesia department there in light of the way that COVID is evolving there in the southern part of Germany. So Dr. Farrell, thank you very much for joining us today.
Thank you for having me, Justin. It's kind of a privilege for us because my podcast is just kind of a mom and pop, recorded in my attic or basement where we can get in. So, kind of getting to branch out a little bit is kind of exciting for me. So thank you for having me on as a guest. I'm sorry my normal co-host can't tune in. They're in various stages of quarantine / unavailable. So you unfortunately only get me.
Well, I'm very pleased to be speaking with you today, and thanks. I know things are very hectic. They're getting pretty crazy here in Philadelphia as well. So I'm really interested. Maybe just give us a brief description of kind of what your current situation is, as well as how long you've been in Germany. I know you were in the States, you were in the Army, you were at University of Kentucky on the faculty there for a while, and then describe for us what's going on there.
Yeah, so for our listeners, I've kind of bounced around a little bit by my choice. So I did a military residency and then served in the U.S. Army for 8 years total, including my residency time. When I finished my service obligation, I took a faculty appointment at the University of Kentucky and taught residents for 6 years there. And then when I was active duty Army, my wife and I kind of mutually agreed that if we had an opportunity to ever make it over to Europe to a duty assignment over here, and then they got short-staffed in Launchville, Germany, and the Army opened up a contract with a contracting company that is my employer, and they got me over to Germany. So I ended up resigning my position at the University of Kentucky, of which I am in talks with our former chair to go back there. So it's a 2-year contract here. I plan to go back to Kentucky in 2 years, but just kind of it's a midlife crisis without buying a house, a car, or getting divorced.
That sounds like a great little excursion for your family. And obviously, when we had started talking, we were interested in talking about, let's do a career overview, talk about your experience in the Army, and talk about some personal finance stuff that I had done. And since then, obviously, the coronavirus situation has been evolving very, 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 very quickly.
Yeah, it's definitely a different landscape now.
Yeah, I know. Like at the beginning of last week, I was like, "Oh, I'm aware of it. I can see the impact that it's having on markets." And then I listened to a podcast. It was the Joe Rogan podcast with the epidemiologist from University of Minnesota. And then I was on like Red Alert. And then I'm all the doctors that I'm following on Twitter who are all. The thing that's really alarming to me is like it seems like all the people who know the most about what's going on are the most alarmed, and especially as it relates to healthcare policy and public health, like the types of changes that we're trying to implement at a broad society level, it feels very urgent. And so I'm really interested to hear, what's the climate like right now. Describe a little bit about the hospital that you're working at, and what kind of precautions are you guys taking?
I work at Landstuhl Regional Medical Center, so it's a U.S. Army hospital in Landstuhl, Germany, which is about an hour and 10, 20 minutes from southwest of Frankfurt. So it's kind of a staging area that the Army's used for a very long time. It's kind of gotten a little bit more of a platform for the wars in Afghanistan and Iraq, where it's kind of a stopping point for war wounded that are, stable, unstable-ish, and kind of need to like not be flying and get to like a medical team. So that's kind of our primary mission. But in times when we're not quite so busy with warfighter movement, then we do regular community hospital stuff like hernias and gallbladders and orthopedic surgeries, and it's probably right now in 2020, it's probably about 80% like routine community type cases, and then like 20% things that have gone awry in a forward operating space and need kind of some advanced medical attention from trauma management or ICU care, what have you. So that's kind of the snapshot of our hospital, is that we have capabilities for trauma and for ICU, albeit we don't have a giant ICU. It's not like where I came from at the University of Kentucky. That's a very large level 1 trauma center that's equipped to handle a lot of like just chaos all the time. So we're kind of get it, treat it, and flat out. So this particular type of issue among the healthcare climate is, we really kind of are getting ahead of it as much as we can with, the good thing we have is that, the primary population that we serve here is military population. Military population is fairly compliant because they follow orders. Like this is their jam. They're like, you do this, yes, sir, sleep the flagpole, do that. So we don't have quite the same social challenges as what I would expect in our civilian hospital at the University of Kentucky. And talking with some of my friends there, I don't really have a good picture for that yet. I haven't gotten into that with enough of my friends there to really get a picture of what it's like in Lexington right now. But we are, we have the control of like, everybody's paycheck is going to hit. So the financial aspect of it isn't quite as big a footprint for us, where like you don't work your hours, you don't get your paycheck. Like, that's a problem. So, our work units are able to shut down. They shut down like the child development centers, which is like the equivalent of like daycare for the military. So, parents are staying kind of home with kids, and travel's been restricted to just, kind of everybody's kind of planning to kind of stay home-ish, because the epidemiological impact that we're starting to understand from, the professionals that are kind of breaking this down, is that the infectivity of this particular virus is substantial. So, the things that we know so far, we know that it's very detrimental to immunocompromised patients. Fortunately, we don't have a whole lot of those within the military landscape, but we do have a lot of retirees here that do get care at our hospital. So secondarily, we also know it's not great. Like, the numbers for morbidity and mortality start to go up substantially as we start to get like, 50, 60, 70, 80. So the footprint of that is to kind of prevent the spread population wide, to kind of get it to be a little bit of a smoldering slow burn, rather than like a raging fire that just blasts through. Because most healthcare facilities are going to have a very finite amount of resources, like ventilators. And ECMO is not really a capability that we have here. We have ECMO teams that can fly to us if we need that, but that's kind of on a case by case basis. That's not a en masse like 20 patients. Like that's a bad day. That's a day that we're not going to get to save as many lives as what we want, just because we don't have that infinite pool of resources. So so those are some of our kind of concerns in terms of like we're in an opportunistic window right now, like where we are in Germany, to get ahead of it. So we've closed down clinics. The dental clinics have been closed. We're really trying to kind of snuff down build those break walls so the fire doesn't rage out of control. That's kind of where we're at right now. Elective cases are being canceled. We're actually doing something that I'm assuming our department chief kind of was spearheading this. So it came from somebody a lot smarter than me. It's a brilliant idea. But the way that we're staffed, so we have active duty reservists, GS, which is like a government service. It's like basically it's like you're paid by the Army, but you're not in the Army. You play by some of the rules, but not all of the rules. It's generally a good benefits package, good retirement, but it's not like you're not like fully in the Army. So it's kind of an in between for like me. Like I'm a contractor, so I get paid by a U.S. company. I get a 401k. I've got life insurance, health insurance, dental insurance, kind of conventional civilian model, but like I'm an employee of this contracting company. So in that landscape of who our providers are, we've compartmentalized into like teams. So it's like, 1, 2, or 3 docs and CRNAs, and that's your team. So like we might work on like Wednesday and Thursday and then have a few days off, and we come back next week on like, Monday and Tuesday. And so that way we're not having department cross-contamination of like, I work with Bob and then I work with Joey and then I work with, whoever. And, if somebody gets infected, it's a crapshoot of who goes down. Like you might get a wider spread of the infection, but if you're just working with the same people all the time, if one person goes down, then you can still, the team stands up. So, but that was kind of a clever way to compartmentalize it, at least among the healthcare personnel, so that we're not swapping it around between each other round robin. That it's more of a contained, pocket there. Whereas we can take a hit here and there, but we're not like decimating the whole department.
So how big is the anesthesia or critical care department? How many staff are we talking about where you're coordinating these efforts?
So honestly, I'd have to sit and count how many anesthesiologists we have bodies that are allocated to us, but they're not permanent party. So we have a combat support hospital that's attached to our facility that has, I think, 3 or 4 anesthesiologists that are tied in with that. But they're not like permanent party. Like they'll come work for like a few days a week or a day a week, and then they have to go do like Army things where they're training and setting up a combat support hospital. And then sometimes they get rotated out for what we call hearts and minds missions, where like they'll go to Africa for like a couple weeks, 2 or 3 or 4 weeks, and they'll do medical missions there. If like there's some sort of like weird Ebola outbreak, then they get rolled out for that. So it's just kind of a mobile team that they stay with a hospital unit to keep their core skills up, so they're not just completely atrophying, but they like can get snatched away from that environment like the snap of your fingers. So we've got that one group. We've got our dedicated active duty people that are probably, I think there's 5 or 6 anesthesiologists that fall in that group. And then we have our GS and contractors, including me, and there's probably 2 or 3 of us that fill those slots. And then we have reservists that are activated for like, 30 to 90 days at a time. So we have those bodies to kind of filter through. And at any given time, we may have 2 or 3 of those. Sometimes we might not have any. So that's kind of the constitution of our MD anesthesiologists. Now, our nurse anesthetists kind of also fall in that grouping as well. We have several nurse anesthetists. I can't venture a guess as to how many I'd guess maybe we have 10 nurse anesthetists in that same kind of structure of like active duty and combat support hospital and, contract and, GS and reservist.
And I was just looking at the Hopkins map. That seems to be like a pretty good source of updated information. I didn't realize Germany is actually like on the short list of top handful of countries as far as total cases counted. Can you talk a little bit about like the public health response? How's testing going? How's isolation and like social distancing going there? And how has that been communicated? Has it been coordinated?
So, honestly, we don't consume the German media. So like newspapers and like German television and things like that. So I don't have as much exposure to like the German speaking aspect of it, but just in like the like I'll give you for example for like what you would see like not connected to like internet or newspaper things like that, like going to Kroger, like a grocery store in the United States. You're going to see magazines and newspapers and like all of that media stuff it's pretty like weekly cycled or 2 week cycled. They really don't have that here. So that type of presence, that I would expect, and Germany doesn't have quite the same technological plug-in that we have in the United States. Like people have smartphones here, and there's that access to it in that way. But like, it's not like the United States. Like you'll walk into like a doctor's waiting room, like there's a TV going, and all this other. It's not like that here. There's no TV. There's no. So the blast of like media everywhere you go, from like the grocery store to the doctor's office to like the bank, or where they don't have that here. So like I don't know how the average German actually consumes their media, but in terms of like social interaction, like uh, our next door neighbors were going to a birthday party at one of the German, like they've got these like indoor swim areas here. They're fantastic, like just fun places to take your kids go swimming. But with this, like on Saturday, it was really not populated. So like the Germans were participating in isolation. But then on Sunday, my wife and I went to there's a mile and a half from our house. There's like this little hut that's outside, and they serve typical German foods like knockwurst and bratwurst and currywurst and pizza on a baguette and beer. And so we walked down there with our dogs, and it's outside, so people aren't on top of one another, but it was pretty busy. There's probably 70 or 80 people in a radius of something that would be like uh, maybe like half of like a college football stadium. So it's a big area, and people aren't on top of one another. But like everybody's kind of congregated around. There's a line up to like the little shack where people are going to get their food and beer, and so there's not that like overt fear of it. The grocery stores are not crushed here. I know, and talking with a lot of my friends there, that there's been a lot of kind of like buy, prepare for Armageddon. That is not the case here. My wife literally just came from the grocery store 3 hours ago, and it looks like a normal day. So Germans also don't like buy and store things like we do. Like in your house, I mean, you've got a fridge that could hold enough food for you and your wife and a couple kids for like probably a week or two. Our primary refrigerator that came with the house that we're renting right now is the size of like what I had in college in like a dorm fridge. That's it. That's what came with the house. It's like built into like the kitchen cabinet. The freezer part of it, literally, if I could put like a Stouffer's like, French bread pizza in there, that's about it. That's it. So we actually had to buy. I mean, I've got 5 children now. We had to buy another refrigerator, and they don't really sell like big refrigerators. Like I bought kind of a bigger ish, but it literally will hold. It's got 3 drawers that would hold probably the equivalent of like, I don't know, maybe 3 or 4 like soft drink cans each, and that's the size of the freezer part. And then the refrigerator part, will hold like a watermelon, and like getting a full size pizza box in there. It's like you have to bend the pizza box. It doesn't fit straight up. So they're not really built to like store a lot of like perishable food. And the typical German will go to the grocery store. Like the way they're structured here is not like the United States. They're like, it's like a village, and then the villages are like where the people live. And then even like the rural areas that are like agriculture, where people are farming and doing things like that, there's like they live in the village, and they walk or drive out to their farm. You can literally walk doggone near anywhere here, just because of the way, like these villages were all built before like there was a lot of like husbandry, like animals and stuff. So there's no fences. Like you can walk from village to village, and the train networks go to like all of the villages. So if it's something a little bit further, you can take a train. Like you don't really have to have a car here. It's fascinating. But with that type of, it's kind of built to be isolated. Like it's not hard for the Germans. They go about their day to day life. If they want to travel somewhere, they can. They've got access to the train network, but they just want to sit and hang out and walk to the grocery store, or ride their bike or whatever. Like it's it's a very pedestrian abled community that can exist on a micro or macrocosm just because of the way it's structured. Like the little neighborhood segment that we live in, there are a lot of multi-family homes. There are a lot of units that will have like 3 or 4 families living in it. It's in a house that's like, there's so much variation in the country. It'd be difficult to compare to something. If you can imagine like maybe like a Holiday Inn Express, that would be maybe like 4 rooms of that kind of like mashed together. But Germans spend a lot of time outside. Like the houses, like you go in and you know, eat and sleep and go to the bathroom there. But like there, you know, a lot of Germans spend a lot of time just like outside doing, you know, going to work or doing outdoor things. There's not a lot of homebound people.
Yeah. Has there been like public health guidance in Germany that has like, I mean, in the States here, it's like sort of like dominoes falling, and it's one by one. It's like going from recommended, social distancing to like mandatory shutdown of non-essential businesses in certain areas, and then they're ramping up the 250 or smaller gatherings outlawed down to, in the state of Washington now they say no more than 25, and I expect that that's going to keep on the bar's going to keep on getting lower. Is there anything like that that's happening right now?
No, that I mean, there's no like militaristic presence of like they're really hammering out hard numbers for like. It's just kind of like the culture is different from the standpoint of like they adult better than we do. Like in the United States, it's almost like the municipalities and the local governments and even the state and national government, they're very parental in terms of the way that like responding to something like this because Americans are very rebellious. Germans are not like that. Like in general, like most people like drive the speed limit. Like in the Autobahn where you can drive like however you want, that's why they have that. Like if you want to go drive fast, you go drive fast there. But like in a village, like no, you don't drive like, 90 kilometers an hour in a 30-kilometer zone. You just like you don't do bonehead things. And if you do things like that, you are very much socially like outcast, like that there's a lot of self-policing here for things like that. Like you're expected to, with great freedom comes great responsibility. Like don't be a butthead.
That's I guess the two-edged sword of the spirit of American rugged individualism is that in times like this, it just looks like mass idiocy, where we're looking at pub crawls on St. Patty's Day and like these fist bumping dance parties in these clubs in some of the cities here, and it's just like you just have to smack your forehead.
Yeah, the Germans don't seem to be doing that. They're very into like following rules. I haven't seen like just flagrant like people being clowns about things. So there's reasonable social distancing, but that's like the normal here. It's not like somebody's like right up behind you in like a line at the grocery store at the gas pump. But that's normal. That was the social interaction before this stuff started. It's not like people they don't just crowd in on one another.
Is there a sense that the growth rate of things with Corona in Germany or other elsewhere on the European continent is like, obviously North Italy is kind of ground zero for the warning.
And geographically, that's not terribly far from Germany. I mean, the Alps are kind of geographically what separate, Switzerland and Austria to a certain degree are there as well. But I think there was enough of an affect of Italy and then Germany paying enough attention. They're like, oh crud, this is the thing. Because I think initially, much like most of the world, everybody kind of just discounted it like, it's the flu, we'll be fine. But the two things that we realized kind of as it was happening in Italy is that number one, this is an incredibly infectious agent. Like its transmission is substantial. Like it's a thing. And then number two, we don't have herd immunity to this, so it's going to sweep through like wildfire. So in the experience of fatalities, yes, it's good that we've pointed out that the age groups, there are certain ones that are going to be more at risk than others. But like I pointed out earlier in the podcast, like we still have a substantial amount of the population that's aged 50, 60, 70, and when they get sick, they get really sick, and that requires a lot of resource consumption. And then when you couple it in the fact that like you start to take out the healthcare workers that are also kind of falling like dominoes with it. But in terms of the German hospital experience, I don't work in one of the German hospitals, but my wife did deliver a baby in one in January.
Congratulations.
Well, thank you.
A little ray of sunshine in a time of like some deep concern.
Yeah, but at the same time, I've got a 2-month-old at home, so we're kind of like, well, we're kind of playing it close to the vest.
Yeah, we have a 3-month-old here, so.
Yeah, well, you're in the same boat.
So, are there any concerns about like supply constraints, PPE, or like ventilators, or beds, or staff? To be able to, if sort of the rising tide continues, to the extent that you expect that, do you feel like you're going to be able to meet the demands for incoming patients?
So we have the ability to expand to like wartime surge. The military stockpiles things all over the place. So we have rudimentary abilities for kind of like, to be able to take care of someone in a stable environment until we can kind of like ship them around to a bigger space. So in terms of like, expansiveness, we can absorb a lot of that, but in the same time, depending on how much of the stress level is, it would also be an avenue where we would have to kind of move bodies around to compensate for the workload. So we have, the space and the equipment for it, but right now our personnel would have to be augmented. We could kind of get the ball rolling and get it started, but it would be a situation where if we didn't get, kind of reinforcements, within a week or two, that it would become overwhelming.
Do you feel like there is a place from which those reinforcements can be drawn, or is it? I mean, it's not hard to imagine in the states here, and I don't want to be alarmist, but I'm looking at some of these numbers and some of these growth rates in some places, as well as some other locales in the states where there seems to be like total a blind eye being turned. Where I have to think that it may be all hands on deck back home pretty soon.
Yeah, so the nice thing about the military is that depending on the relative need and the way that they're communicating, if something's really bad, we can generally get the bodies moved where we need them. That being said, it's very uh, disconnecting for like someone that lives in like San Antonio or Washington D.C. To all of a sudden get loaded up onto a plane like, hey, you're heading to Germany and you're going to be there for some time period. We don't know how long, but like get your butt over there now. So there's that degree of disruption that like if something's bad enough, like things happen like that. There are orders and things that have to go down. But if something gets really sideways, we have that ability just to kind of like drop orders, move people, and because the military has its own network of helicopters and planes and lions and tigers and bears. Oh my! That's one of the reasons that I want to come back to military hospitals. Military personnel are generally very selfless. Like they're used to kind of getting knocked around a little bit because it's Uncle Sam does what Uncle Sam does, and sometimes it's in the service member's best interest, and sometimes it isn't. But generally, it's sometimes you get the thing that you don't want, but maybe the next time we'll get you the thing that you want because we know that you took one for the team to take this job that nobody else wanted, but we can help you up on the back end. So we have that access to those resources in terms of like we're not on an island by ourselves. It's just that we have to be built to survive a lean time for a while. The cavalry will come. It's just the how the machine will move to get us the things that we need, where we need them.
I'm sure there's a lot of things from an organizational and like a mindset and just a scale standpoint that you're uniquely. You could argue like the Army hospital is uniquely positioned. If you kind of look at historically, if there's a big battle and all of a sudden you get like 1,000 people that show up that are all like in bad shape, you've got to be able to quickly, the wartime triage that frankly, like we're hearing about is happening in Italy right now. I'm curious, what advice would you give as somebody with, military experience, Army anesthesia experience, and somebody who's in a hospital that does have this ability to scale based on that sort of mindset? What word would you want to give to the big academic centers and the bigger, groups here in the States that are trying to like prepare for this rising tide to be able to address perhaps overwhelming patient need?
I think because of the unique nature of this disease, the infectivity, I think the one of the first goals that every facility has to have is to maximize protection of their personnel, because the facilities and all the equipment and all that stuff doesn't matter at all if you don't have effective bodies there to make the machine go. So the first priority in all of these environments has to be protection of the hospital personnel, because that populace has a very unique skill set that when taken out, it's not just one domino falling, it's multiple dominoes, because the footprint that person will have on making a difference in other sick people it's a force detractors. So in the Army, we have things that are force multipliers and force detractors. A force multiplier is something that makes one person have the effect of 10 people. So like an anesthesiologist is force multiplied by nurse anesthetist, and your nursing staff for any physician in the hospital, because they make you able to be in like 5 or 6 or 10 places at the same time. But if those items aren't supported, and you don't have your nurses, and you don't have your respiratory therapists, and your anesthesiologist and nurse anesthetist are sick, they can't function. So that has to be a primary goal of, like, protect your personnel first. Secondarily, I think that just knowing what your capabilities are, and then figuring out ways to either augment them or move things around, or have a transfer line to get somebody to a facility that you know gets the capabilities that they need. Now, not unfortunately, not everybody's going to need ECMO from this, but if you're a small community hospital, like, you have to make those connections now, before it's like, John Q. Public just showed up and, like, his lungs are not functioning and he's going to die. Can we send him to you for ECMO? I was like, well, this is the first time you're calling me. We don't really have any plan in place for this. So, we've got to answer some questions before this guy shows up and, like, sheds deadly virus all over our facility. So, so if the community hospitals haven't had those conversations with the bigger centers, then that's a problem. As far as the bigger centers go, at the University of Kentucky, they would do these drills every month, every couple months, where it was basically just kind of almost like a mass casualty drill, and it varied from things like, Lexington is a hub of, like, industrial liquids that come through. I mean, they've had small but kind of contained things where they've had, like oil or some sort of, like, weird hazardous material where they, were kind of spun up and ready to take a massive group of patients. I mean, a year or two after I left Lexington, they had an aircraft go down at the Lexington airport. So that was a big mass casualty response. When I was on call one night, they had a train that derailed. And was right next to a trailer park. Fortunately, we're literally probably about 100 yards from a giant catastrophe, but thanks to the way the trains didn't have people on them, they were cargo trains, and where it derailed next to a trailer park, but didn't, like, invade the trailer park. We dodged a giant bullet there, but we were prepared for it. I mean, when I got the page coming through, like, I got everything spun up, I got people in place, like, we were ready for. And then it turned out, instead of an N of 100, it became an N of 2. So that was a little more manageable. So a lot of the bigger facilities have these contingency plans in place. So they've thought about these things. They've got these, but an infectious disease presents a very unique risk relative to something like the Army prepares for things like this. Chemical attack. I was the only anesthesiologist at Fort Leonard Wood, Missouri, where they have the sea burning training for the Army there. So they go through those drills all the time, because that's the thing that all of those people have to know how to do. So we set up shuffle pits, we set up decontamination, we set up educational sessions on how to use the Mark II 2-PAM chloride atropine kits. So the Army trains for these things a lot. We kind of take it for granted, the active duty folks, and we grumble about it because it's like all of this crap that they put on our plate all the time. And then, like, it actually goes down, and you're like, crap, that was useful. So, so somebody has thought about this, somebody's kind of got a game plan for it. And, but just kind of getting the mechanics of, like, this is how we do this. That's the first round of hiccups where, like, it looks ugly, the first little bit of it, but then, once the numbers start to kind of climb and pile up, then you've got, okay, we did this way last time, we're going to do it again. Now we're going to do it again. Now we're going to do it again. So,
in your opinion, is there enough of this type of, like, mass casualty type training that has happened in our healthcare system that we're going to be able to adequately deal with some of the issues that we're going to hit? Or are a lot of people going to be obviously probably learning on the job?
I think there are two things that are going to make a big difference in terms of kind of how this plays out. Number one, it's going to make a difference in how the American public treats it. If they are like the Italians, and I was deployed with a lot of Italians, so I've got kind of a general feel of kind of how the Italian culture is. It's very much a lot of bravado, machismo, like, I can't get sick. And so I think they really didn't take it serious initially, and really kind of gave it best case scenario for kind of getting out of control. So I think if the American public really, kind of gives it its due, like we're not super afraid of it because like 20-year-olds, there's not going to be a mass of 20-year-olds that we're digging graves for, but like we need to keep it. We need to keep the social contact down because while you might not be afraid of it, like Bob's, pawpaw over there, he gonna get killed by it, and it's gonna get transmitted more distinctly if we all just kind of say, "Oh, this isn't so bad. People aren't dying en masse." It's not that people are dying en masse; it's that as it sweeps through a populace, there is a vulnerable population, and you're going to expose them at a higher rate if everybody else acts like, I can't be damaged. I'm 20 years old and I'm bulletproof. Look at me jump off this building. That's great. Maybe you're going to land on your feet, but you're going to create enough shock waves with how you hit because of all the disease vector that you pour out because you got sick, because you were a bonehead, and now 10 other people are sick, and it's a magnifying effect. So I think that's going to really shape how this impacts our healthcare system. And then kind of the last crux of it is how the healthcare workers and the doctors and the nurses and the hospital administrators, how they prepare for it. Because on the spectrum of what can happen, it all ranges from like everybody's super well prepared and it goes off without a hitch. That's not going to be most hospitals. Most hospitals are going to be kind of somewhere in the middle where they're going to make some mistakes. They're going to have some gaffes, but learn from it and then adapt quickly. And then the dangerous ones are going to be the ones on the other end of it that are like scared to death and try to put their head in the sand like an ostrich, and don't face it bravely and smartly and try to educate themselves about proper practices. The CDC has been tremendous, and several university centers. One of my partners went to the University of Washington for her training, and University of Washington has been very good about putting out like flow charts and protocols. And there's an EM critical care doc website that I was looking at today that was fantastic. That had a very good kind of breakdown of all the things you need to know as a professional to understand the pathogen and like how to get a game plan for it, because we're still in those early stages of really learning what the footprint is going to be on our society. But like the things that we know are the things that you need to really plan for. Started out the podcast and so we know it's going to be super contagious because we don't have a herd immunity for it, and so we need to play that game. There was a reference that I'd come across where they'd referenced the 1918 flu epidemic in Philadelphia that didn't do a particularly good job of cutting down on those public gatherings and like church services and all the things that got people together, and their mortality rate per 100,000 at that time I think was there's reference that are like 250 deaths per 100,000, which is not a huge number, but still that spike in infectivity and the populace that was affected was substantial, whereas St. Louis within a couple of days, because they had already seen the experience of what was going on in Philadelphia. There's a lag time for this by about a month. They'd already seen how it was sweeping through Philadelphia, and they're like, "Oh crap, we need to like shut everything down now." So their arc of what their disease foundation was among the populace had a mortality rate of 50 per 100,000. That's a five-fold decrease just for a few weeks of like not going to the theater or not going to church, like just kind of hanging out and just staying close to home. And the cost of that individual family isn't substantial. In 2020, it may be some lost wages from work that's missed. I don't know what the answer is for families that are financially a little bit more at risk. But for people that can, afford to stay home, or like, just the obvious things, like I didn't go to that water park on Saturday because if I were to pick a petri dish of something that's going to transmit virus, I pick a water park. Talk about droplet transmission, but it's just kind of being smart. You don't have to be afraid of the world. You don't have to outdoor stuff like hiking. Like I went through like the woods. There wasn't like open corona in the woods because the respiratory droplet burden there's not high. It's not a zoonotic infection from dogs or cats or deer or whatever. I don't know what sort of wet market stuff they were doing in Wuhan, but
Yeah, and that's one of the things I guess that's, and even today I was talking to a client of mine closer to the Midwest, and they're still doing elective cases at all these big hospitals, and they're doing like no additional PPE for even at risk faculty, and it's so slow. This is the thing that frustrates me, is it's so slow to see these changes being implemented, and unfortunately, especially in some instances, if you have a surgeon who's got a bunch of elective surgeries lined up, there's sort of this inverse incentive, to cancel, and it's a tougher thing to do. But in the interest of public health, it seems like at this point it's a no brainer. And I'm just looking across, med Twitter and all these how slow it is, even in this day and age, and it is a little bit like watching that train wreck in slow motion. So this is just, I think, an opportunity for me to reflect and say I'm really grateful for the people out there on the front lines, people like you, Dr. Farrell, and like my wife here at University of Pennsylvania, and all of her colleagues who are going to be working a lot of overtime, putting in a lot of hours and a lot of hard work as we see this thing continue to probably pick up steam, and really putting themselves at risk to try to keep our populace safe. So,
yeah, I think that's what makes military medicine and university medicine different than a lot of the community hospitals. It's like money makes things perverse. And I worked in a small community hospital that was private practice, moonlighting when I was in the military. I got to see a little snippet of that, and I got to see surgeons that were not necessarily that they were openly willing to sacrifice the well-being of their patients, but like they were going to make money every chance they got. And unless they saw something that was a clear barrier or like a terrible practice or something that's going to hurt people, then they were just going to do it their way, damn the torpedoes, make money, and just take a whiz on everybody else. So I have seen that, and that is an ugly way to practice. It's one of the reasons that I didn't go into a private practice environment, because I didn't want to have to be compromised in that aspect where like money makes decisions for me. At that point, I think it's really up to the administrators to just kind of like, because they're going to be the final gatekeeper. As much as I'm not a big fan of strong hospital administration, period, but I think that if they have a role of any kind of gatekeeper guardianship, like if there's a part of the machine that can stop because physicians are held in a very revered platform, but we're human too. There are things that affect our decision making. You can't function in a vacuum. You have to have other brains chiming in and have the courage to kind of speak up and say, hey, like that's not a good idea. Like this thing that you're doing right now, this is the playbook for the bonehead way to do it. So you really have to have somebody, and it's hard. Those communities there, I've been there. Like your kids go to school together. You have barbecues together. Like your cousin and somebody else's sister are married, so you're related to somebody. So it's a very tight niche group that is very easy to fall into groupthink, because there's an alpha within that pack, and then so and so said such and such, and that's gospel. So that's the part of what gets weird about it.
and then it becomes what we see as like least common denominator, both medicine and society, where it's like, oh, well, so and so is still doing it, so it must be okay. And that was what's happening for this person I was talking to at this big center closer to the Midwest, where it's like, well, the big academic place in town is still running electives, so the smaller private group is going to keep running electives until the big group says no. And then it's like, it's abdication of responsibility, in my opinion.
It's too late then. That's the problem. It's too late then, because we don't really know what the incubation period of this thing is right now. We're kind of guessing, and it might be as long as like a week or two. And that's just going to be absolutely devastating if that's kind of how it plays out. The other thing that I find personally most concerning is that there seem to be a substantial amount of patients kind of out in the community that are like infected, shedding virus, showing no clinical symptoms. And that's like a perfect vector for just laying waste to entire populace, because that person's going to have, especially if they're working in the hospital, because they're going to have contact with a bunch of compromised patients, and it's going to get ugly. So I think at least until we kind of get on the downslide of this, I think we really need to strongly consider pairing down some of those cases. And I get that it's hardships on the patients that are coming in for these elective surgeries for, like, their cataract surgeries, that their son's taken off work to take care of them for a day, and they've planned to have their follow-up visit, the next week, and like all of this stuff's in place, and to just stop the brakes on that, that's a hardship to the patients. But what's going to be more of a hardship is if this really starts to get out in the community and just bashes everyone, like, yeah, get your eyeball fixed, but now you're fighting for your life on a ventilator. So what was the better decision? And we don't know the answer to that. We don't know. We don't have a crystal ball, but I think, by the time you're reacting to it, it's already too late.
Yeah, and there's so much unpredictability. I think more than anything, the one thing that this is making me think about, and I'm curious in your perspectives on this, and then we'll wrap it up here, is that it's important to sort of acknowledge our shared humanity and the fact that there's a lot of freaked out people and a lot of vulnerable people and a lot of people who are powerless to improve their own situation or to protect themselves, or who don't have an economic safety net. I'm looking around, here in University City in Philadelphia where I live, and I could throw a rock and hit 20 different houses where people don't have 6 months of savings in the bank, and they're working on an hourly job, and the way that they're thinking about this is it's very different from like me and my wife and our household. And it's important to acknowledge that and to reach out to people around us and say, hey, neighbor, friend, family member, like, we're in this together, and maybe we can only talk on the phone instead of hanging out together for a while. But that acknowledgement of shared humanity, of saying, like, if you need something, I don't have a lot, but I'll give you some of what I have, and creating that person to person community bond. Again, in this age, it's like, it's dissolved to some extent because of the way we interact electronically, I think. But I think restoring that, it's going to be part of what makes this easier and better for us to get through as a society, as a community. And I think it's as important as it's ever been.
Well, I think this is an opportunity for, America, Germany, the world, because everything's a lot smaller. I mean, I can, before the virus broke out, you get on a plane and be back in the United States in, 8-10 hours. And, the world's, as big as it is, as smaller now as it's ever been. So this is almost like a dry run for, like, it's the way we're connected. It's the perfect petri dish for, like, something really bad. Like if we had some sort of like sustainable, like, Ebola strain that has like a 90% kill rate. So how we respond to this now, in terms of both kind of the panic, the education, the knowledge dissemination, really kind of gives us a framework for how we're going to respond for something that is clinically more significant. So we're blessed from a standpoint that for the majority of the population, it's not going to be a catastrophic illness, but we have an opportunity to kind of learn the social changes that we need to make to get into a place where, if this were a more substantial pathogen, that we already know what to do. So, and it's very much in something like this. This is not a me item. This is an us item. This is we. This is our community. This is our world. And so the way we respond and learn from this event, or don't learn, will really kind of set the stage for it's not if, it's when and how bad. Like we're genetic vectors for bacteria and viruses and all kinds of other things what infect us. And this is an example of how we can work together to get everybody through this. We see it in the economy. We see the stock market going down and panic, and like that's not the answer. Like there's certain aspects of business as usual that can continue on, but but there's certain like things that we do socially that we can modify so that we're helping each other collectively.
Dr. Shelly Farrell, thank you very much for joining us today and for sharing your experience on the Anesthesia Success Podcast. Hope to talk to you again soon.
Yeah, well, and then a last little nugget for the anesthesia providers out there, like, take care of yourself. There's a lot of guidelines that are out for wearing N95 mask and personal protective equipment, because I think anesthesia personnel are taking a substantial amount of exposure and infectivity of patients, exposing the healthcare providers to it. So eye protection, the N95 mask. I mean, that's what we're doing at our hospital to cut back on some of those. So I know that's going to be the N95 masks don't have the same prevalence as like the surgical masks, but it's the onus of the hospital to find, routes to kind of get that equipment in. And the military's also learned that like you can reuse these things, like you can decontaminate the outside of the masks, and so you don't have to like use one, throw it away. This isn't JACO time. This is like pathogen survival time. So you can decontaminate masks and reduce that risk. But so the anesthesia people out there, take care of yourself, because we really need the anesthesia people to stay in the fight.
Yeah, it's absolutely right. Well, Dr. Farrell, thank you very much for your time today and your perspective.
Thank you so much. Thanks for having me, Justin.
If you liked what you heard this week, head on over to anesthesiasuccess.com, where you can find more content and free resources to help you build a successful career in anesthesiology and pain management. If you wanted to leave a review in iTunes, I would also really appreciate it. Thanks for using some of your valuable time to join me today on the Anesthesia Success Podcast.